Welcome back to INP4, the unit on pain management. So far, what we've looked at in the previous videos was the notes. No, sorry, we looked at the epidural diagram, looking at a quick overview of PCA epidurals and a quick chat about PCAs. So spinals, epidurals, and PCAs. And then we took a quick look at the acute pain management flow sheet. Now, using all that, we're just going to take a look at this notes on anesthetics and analgesics. So this should hopefully make more sense to us now. Okay, so looking at this from the top here, so is it possible for a patient to score 3 or 4 on POS, remember that's unacceptable, and have 10 out of 10 pain at the same time? So the answer to that question is absolutely yes. You can have patients who are pretty drowsy and still having a lot of pain. What do? Pain's what the patient says it is, but yet I'm talking to this guy, he can hardly keep his eyes open at all, and I need to really shake his shoulder quite hard to wake him up. I'd say that's probably around a 3, maybe a 4 on POS. That's too drowsy. What do? Well, let me tell you what you don't do. You don't give him more meds, and you may have to hold the meds. So it's kind of life over limb sometimes. Is this a common scenario? No. I mean, not for me. I don't see this often at all. But it can happen, and if it does, you need to stop the opioids going in. You need to wait till he's less drowsy, a 1 or a 2. Again, not a common scenario, but it just kind of really illustrates that, you really need to be paying attention to level of sedation, LOC. And what comes first, given that things happen slow enough, what comes first, a drop in respiration rate or a drop in level of consciousness? Typically, it's a drop in level of consciousness that happens first. That's your warning sign. That's when you got to start to back off, or there's going to be some risk to, respiratory functioning. Okay, so I've already done an overview of anesthetics. You can read this again for yourself. But the main purpose of this is you want to talk about how the anesthetic takes action. So you've got the spinal that's being injected, or you've got an epidural that's infusing, either in the surgery or on the ward. And if you start to increase the amounts of anesthetic that hits the system, how does it work? Let's talk about the epidural first. So as it starts to hit the system and work, the first thing that's affected is the sympathetic system. And so there'll be a vasodilation at the area of effect and basically a drop in systemic blood pressure. That's the first impact these will have. Next, pain is blocked. And that's where temperature and sensation starts to change too. That's what we talked about with dermatomes. There'll be a slight decrease in the sensation of temperature. There might even be some numbness sometimes, but typically that's the third level, is complete numbness to the area. And then if you get enough med in there, you get complete motor blockage, which means they can't move their extremities. So at what level does a spinal, when someone gets that one-shot spinal in the OR, with a set amount of anesthetic going right into the intrathecal area, right around the spinal nerves, what are they shooting for? Level 1, 2, 3, or 4? They're shooting for level 4. They're shooting for complete motor blockage typically in the OR, and so they'll give that spinal to achieve that. So there'll be enough anesthetic going right into the intrathecal area to achieve motor blockage. So what happens as that spinal wears off? They get up to the ward, it starts to wear off. What returns first? You got it. Motor function returns first as that spinal wears off. Then they start to feel some sensation in the area. They might not feel any pain yet, but they start to feel sensation. At this point, if you did a dermatome check, when you hit the areas that are affected, they're going to tell you they're numb. They're going to say, yeah, between those areas of whatever, around about the L1, L2 area and a little bit on the other side of it, I'm numb. Then as the spinal wears off more, then what? Then they start to feel pain in those areas, or maybe they start to feel sensation in the areas and hopefully not pain, And so they're telling you, yeah, I don't feel too much pain in the area right now, but so they say, I don't feel pain, but I do feel when you run the ice over it during your dermatome checks. However, it doesn't feel as cool as it did when you had it up against my cheek. That's typically very normal, and that's typically what we're shooting for on the wards. That's what we want when there's an epidural running on the wards. Typically, we're shooting for number 2 with the epidural. Now, I know from experience, and you may too, that sometimes with the epidural, you're actually hitting number 3. It's not ideal. It's not necessarily a bad thing, but you certainly wouldn't be able to get them to walk if that was happening in the lower extremities. That would be dangerous. But if it's number 2 in the lower extremities, we can probably get them to walk with that. I mean, follow your protocol. And then the last thing to return is, of course, that sympathetic tone, where the blood pressure will come up to its, how do I say, regular level that it should be at, if that's even appropriate to say. Typically, we see a lot of patients with decreased blood pressure after OR, and that could be because of blood loss, that could be because of some dehydration, and typically we can definitely throw in the effect of meds, narcotics, and anesthetics. So things take action from 1 to 4, things wear off from 4 to 1. So I do encourage you to read through the rest of this by yourself, but that's kind of all I want to say in the video for these notes.